Hi, I'm Dr. Ashley Fuller.
And I'm Dr. Meredith McClure.
And this is Labia Logic,
the podcast that's all vulva, no filter.
We're here to talk about all the stuff your doctor rushed through, the questions you've been too embarrassed to ask, and the sex ed that barely mentioned the vulva.
Because too many people are suffering in silence with painful sex, menopause misery, and vulvar issues no one talks about.
No shame, no stigma, just real talk, real answers, and the education you should have gotten in the first place. Hello, and welcome back to Labia Logic.
Welcome
I'm here
back
with my wonderful co-host, Dr. Meredith McClure. And we are excited to be here to be talking about discharge more and vaginitis. And I think you're going to really like today because we are going to be talking about the things that most of us don't talk about all that often. And these are the more rare vaginitis or vaginal conditions that you can have that may be harder to get a diagnosis for. I mean, when patients go to the gynecologist and have, vaginitis symptoms, about 70% of them will be diagnosed with something like bacterial vaginosis, yeast, trichomonas. And if you want to hear more about these, you should listen to our previous episode. But about 30% of people will be in this category of all the swabs are negative, but you have symptoms still, and we need to still figure out what that is. And that's what we are going to talk about today. Meredith, do you see these kinds of patients a lot?
So I'd say we see this all the time. And I think as specialists, I don't know about you, but I feel like probably the majority of referrals I get from a lot of gynecologists, primary care, other providers, it's this exact scenario where patients have complaints, discharge, itching, irritation in the vagina. These are vaginal concerns, so inside, and they are getting test after test, be it a urine test, be it a swab in the vagina, and they're just not getting better despite throwing the treatments that should fix these things that are showing up on these cultures. And that is when we have to sit in front of the patient and say, but you're not better.
Right.
It's difficult. It's a hard thing. And many patients have been through tons of treatments and providers. And of course, this is stressful and it takes a toll.
Yeah. And, I obviously we're kind of focusing on like the patient experience, but I also want to say like as a clinician, before I knew about this stuff, it was also really hard. These patients would come back, you'd see them pop up in your schedule again. You just saw them 3 weeks ago. They're not better. And you're just like, oh my God, I don't know what to do. Like I send off these swabs and they're negative, but I know she's not comfortable, but I don't know what's wrong. As we talk about a lot in this podcast, like we didn't learn a lot of this stuff in residency. And these conditions we're going to talk about today are more of like the zebras. We say that in medicine, like most things are like horses. You see them all the time. The zebras are the rare things. These are more rare things. But, we think about 30% of vaginitis cases don't fit in the category of BV, yeast, or trichomonas. And so these are not totally rare things that you're going to see. And, I definitely think this is complicated and not straightforward and challenging. And as a generalist OBGYN busy with a lot of other things, I do think this is a lot. As specialists who do this all the time, I actually find the detective work that happens and the science that goes into this actually very interesting and somewhat satisfying, especially when you figure it out. But this is hard for everyone.
People don't realize this. Your clinicians, they want you to get better.
Yeah.
And it's hard. And we hurt for you too. And so this is why we're doing this and talking about this because these things do exist and we do see them, you and I definitely, and we need to talk about it.
Yeah. I always hope for my patients that they get back to a life where they don't think about their vulva and their vagina on a regular basis. It should be a part of your body you don't automatically think about frequently because it shouldn't be a problem. So,
yeah.
All right. We are going to talk about two main things today. We're going to talk about Desquamative inflammatory vaginitis or DIV. And then we're going to talk about cytolytic vaginosis. And then we're going to talk about some other rare things that also I think are worth talking about when we think about discharge symptoms and irritation and negative swabs. So desquamative inflammatory vaginitis, big mouthful of words, is a non-infectious inflammatory condition of the vagina. It's kind of confusing. Like, wait, it's not an infection, but it's like this inflammation. So almost think of it like almost like an allergic reaction. Like there's some kind of non-specific inflammation that's happening. We don't know exactly why, and it causes really bad discharge, sometimes pain, sometimes burning, sometimes pain with sex. But the biggest thing I see is tons of discharge. These patients say, oh my gosh, I just have so much discharge. I have to wear a pad. The discharge can be kind of yellow green. And like, really, that's one of the biggest signs. And when patients come in with a lot of vaginitis symptoms, I'll ask, like, as I'm trying to figure out, could it be this? Do you have a lot of discharge?
Yeah, and DIV honestly is what led me to the vulva. I know I've said it before in episodes, but I had one patient in particular, and she had discharge, and I was running the swabs, and they're coming back negative, and I couldn't figure it out. I looked at her and I said, I feel like your vagina skin is falling out. Like
Yeah.
it is literally this much discharge that you'll see. Like I've had people say, I can't even go to work today because my discharge is so copious.
Oh my gosh.
And it can be super irritating. This is kind of what DIV will look like. And of course, being the hormone nerds that we are, we will also start, coming in. I have all this discharge and irritation. We will start asking you, what are your periods doing? Are they regular? Are you 47 years old? You're starting to miss them here and there. And you have hot flashes and night sweats. There's a lot of people that this will present in these hormonal fluctuations of life, including the menopause transition known as perimenopause. It's kind of important to note that if you're having anything like this in this kind of flux time. Now, you definitely can see DIV in people not in this time, in the perimenopause or the postmenopause time, but it is fairly common, and you see it, and it will be in someone in their, 40s, 50s, 60s, even like 70s. So
Again, all these things are not common. This is not a common thing that we see. I mean, we see it, more commonly than most because of, the patients that we get referred to us. But, they say about 5% of patients will have DIV when they come in for vaginitis symptoms. So not very common, but yes, more common in like when there's hormonal shifts. So perimenopause, menopause. It's thought to be kind of the severe end of aerobic vaginitis. So you may hear the term AV or aerobic vaginitis, and that's really like an overgrowth of aerobic bacteria. So E. coli, GBS, Enterococcus. I'm not going to get too deep into all that. I mean, really, that may be the precursor to turning into DIV, but DIV is thought to be sterile. Like, and basically, there's not a ton of bacteria in there. It's really kind of more of an inflammatory reaction. Isn't that how you think of it, Meredith?
yes, we still have to figure these things out, but even some of our vulvovaginal dermatoses, possibly like lichen planus with the erosive changes and the inflammation, is it related? Is it not?
Right.
Possibly, we don't know. Is it a hormonal thing? Is it a menopause thing? But something is causing you to have inflammation in your vagina
Right.
and causing these symptoms.
Yeah. When you have this condition, you have, like what Meredith said, like the skin of the vagina is kind of sloughing off. You have like this inflammation. You have so much discharge, tons of parabasal cells. These are like the first layer of cells, and the vaginal mucosa, lots of white blood cells, and you're basically lose all your good bacteria, your lactobacilli. And so when you without that lactobacilli, you get this high pH. So one of the things we always see when we have patients come in, Meredith and I always do pHs and always look under the microscope. And I will tell you that if you don't have a physician that's looking under the microscope and doing pHs, they're going to be guessing that you have this based on symptoms. If they're diagnosing, you really have to have a microscope and a pH and pH paper to really truly diagnose this.
Yeah, there isn't a swab that comes back and says this is DIV.
There is not.
And the pH is so important in the vagina. And the reason that's important is the pH of your vagina is supposed to be very low or acidic. And when we use it's a little strip of paper, and you can just either put it on the side of the vagina if we're looking inside, just touch it inside of the vagina, or you could even take a Q-tip and rub a little bit of discharge on that, and you're going to get the pH. That pH should be about 4 to 4.5 in someone who has a normal pH of the vagina. And that's because these lactobacilli, which are like our little good bacteria, I guess, in your vagina, they make lactic acid as a byproduct. Now, estrogen does feed that. So you can see we kind of start asking these hormonal questions. If estrogen's left the vagina for whatever reason, are these lactobacilli getting what they need to make this pH low? So there's one thing there. So we will see under the microscope, we won't see a lot of these little guys under the microscope, but then we look at the vaginal skin cells under the microscope. They should look kind of like polygonal, like they have like kind of a shape to them that's not round. And then these parabasal cells, which are very immature cells because it's so inflamed in there, and these cells get really bloated looking, and they're big circles. And you shouldn't see that in a normal pH stable microbiome. And then the little neutrophils or white blood cells are these little guys that our immune system makes to kind of fend off things, and it will go up in inflammatory processes. And so you still see these under the microscope. And this is really how you diagnose DIV.
Yep. So high pH under the microscope, lots of white blood cells and parabasal cells. And I always think of them, they look kind of like fried eggs because they have like a central nuclei and they're very like round, which most of these squamous cells are very polygonal. That was a good way to say it. Like, have kind of rougher edges and things. So you wouldn't see clue cells under the microscope. They're not going to have like an amine odor like BV. This is definitely a different situation than BV. BV would have a high pH and you see clue cells and you also have that odor. I guess we should move on to how we treat this, which is always a challenge, I will say. The thing with the treatment is that there is a lot of relapses with this. I think part of this is we don't truly understand why this happens. Like, why does someone get DIV? Is it that there was an overgrowth of these other bacteria and then it goes further than that? Is it actually an allergic reaction to something or is it a hormone thing, right? Because we know what happens during so there's these things that might make you more susceptible, but I don't think we have a real good understanding of why this happens. And so I feel like a little bit like the treatments we have, I wouldn't say they're Band-Aids, but they're kind of treating the condition and not so much treating an underlying reason for it. And because we don't know what exactly that is. Don't you kind of agree?
Yeah, I agree. I mean, the treatments that we're using are anti-inflammatory, and that's, attacking that inflammation. Now, kind of trying to get to the root and figuring it out. Is it a dermatologic thing and we need to stay on,
Right.
like a steroid and to keep that kind of in a maintenance to keep inflammation down? Is it a hormonal thing? I mean, you and I both know that vaginal hormones everyone should use no matter what till death do you part. And a lot of times because this happens for a lot of people in a hormone flux, or maybe they're on a birth control pill or something that's depleting hormones in this tissue, then staying on that to also, because vaginal hormones, estrogen is anti-inflammatory. It's an anti-inflammatory
Yes.
hormone.
Yes.
And it's a growth hormone. It's an anti-inflammatory hormone. It helps with blood flow. And when it leaves, the vagina can get really pissed. And this is one of those scenarios where it will get pissed.
We don't like it when vaginas get pissed off.
No.
No. So the mainstays of treatment for this are 3 different types of anti-inflammatories. It's kind of the best way to think about it. So we're kind of trying to attack inflammation from the different underlying possible etiologies. So one is corticosteroids. So corticosteroids is what we use for a lot of dermatologic inflammation. We sometimes use hydrocortisone suppositories. You can compound these, or you can use Anusol in the vagina, even though it's like a rectal, generally a rectal insert for hemorrhoids. Or people can use clobetasol ointment. I generally don't put a lot of clobetasol ointment in the vagina, but I use the hydrocortisone suppositories sometimes. So that's coming in from the dermatologic standpoint. And then you have clindamycin. And although we think this is a sterile condition and not really a bacterial overgrowth by any means, we use the clindamycin for the anti-inflammatory properties of the antibiotic. And this is not because you're not taking it orally, it doesn't have a lot of the same risks of like C. diff and things like that. But that's another possible way of going about this as an anti-inflammatory. And then third is the estrogen. So using vaginal estrogen to get rid of that inflammation. So I've seen different things. I used to kind of do it by like the recommendation of starting topical clindamycin, 2%, like whole applicator, 4 or 5 grams every night for 1 to 3 weeks. But usually now by the time patients have gotten to me, like they're just so frustrated that I've just like jumped in and started doing triple cream.
Their vagina's super pissed.
Super pissed. So like, let's not, I was gonna say beat around the bush. That seemed a little wrong. Let's not like start with a little bit here, a little bit there. I'm like, let's just go right at this aggressively.
Attack.
And so I think Meredith and I have started doing a mixture of clindamycin, a hydrocortisone, and a vaginal estrogen compounded. And I find it actually works really well. And they don't have to put a ton of cream in. The way you can set it up based on how the concentrations, they just put like 2 grams in. And I usually do that for 1 or 2 weeks, and then I like basically reduce how often they're using it. I do that so that we don't want to have to use this every night forever, but we do want to really get this inflammation down. But the problem is if you just do it for like 3 weeks and you feel good and you stop completely, well, a lot of people, it's going to come back.
Yeah. Yeah.
So
it's tough. For me, it kind of depends on the the amount of inflammation I see. Sometimes I might just do a steroid and not do the clindamycin. Because I mean, clindamycin, when you think about these things, again, yes, we're gynecologists, and then these are scenarios where I'm telling patients, like, okay, look at me right now, like I am like a dermatologist. So, you came to the dermatologist, dermatology hat, putting that on. And then you think about what dermatologists use these medicines for. You have an itchy spot, they're going to give you topical corticosteroids for almost everything. This is a skin thing. So it's bringing down inflammation just like it would an eczema on your elbow or something like that. You have acne, you go to the dermatologist. That's inflammation. They give you clindamycin, they might give you a doxycycline, a topical clindamycin, something like that. They're not giving it to you because they think that this is an infection and they're trying to eradicate infection. They're trying to decrease the inflammation in that skin. And it's the same thing we're doing here. So the degree of the inflammation, how we kind of decide where to go. And then estrogen comes in and levels the playing field and tries to keep that stable pH. And that's why we do the estrogen.
Yeah, and that estrogen bring that pH down, and it also allows for the healthy lactobacilli to grow. And so there's also the thought that you could, and I think we were talking about this with Jill Krepp a little bit too, that you could do the triple cream and then remove the Clinda after a little bit and add a probiotic in just to help really reestablish that really good microbiome. And there are some really good probiotics out there now that are vaginal and mostly Lactobacillus crispatus, which is what we're looking for. We're not going to get too deep into probiotics today.
We might flip the switch and talk about it in a second.
Oh, well, yeah, I'm going to talk about it a little bit, but I'm just going to say, like, probiotics it's complicated. Like, it makes so much sense, but there's not a lot of great data for it. So, although there's some new probiotics that are having a little bit of data.
Although by the time people have landed with us, they've probably paid out the nose for probiotics for these type of conditions because they're not getting better.
So if you're going to the doctor or your clinician and you have tons of discharge and every swab is negative and you're in pain and it seems really like thick green yellow discharge, there's a good possibility it could be DIV. If your clinician doesn't have a microscope to look under the microscope, they could presumptively treat you this way, but ideally look under the microscope to identify this condition along with looking at the pH. It's good to have a specialist treat you for this because the recurrence rates at 1 year are high. So generally, you do have to kind of keep treating this with some kind of maintenance dose, somewhat long-term, maybe not forever, but ongoing until you can kind of titrating off and see how your body does. But I think there's definitely room for more research in this area so we have a better understanding of why, and then maybe we can get a more effective treatment that actually gets rid of it.
Yeah. So we've talked about vaginal pH and how important it is. So this DIV is a high pH problem. But there is actually something that exists that's a low pH problem. And Ashley and I go to vulva meetings, and they're real fun.
They are.
We have fun. We bring the fun.
We are a blast.
But this is a thing that even the big wigs in this space argue about. Does it exist? Does it not exist? And clinically, I feel I see it. And it's something I think a lot of people don't really know exists, and that is called cytolytic vaginosis, or CV.
Right.
So, and then the daughter line cytolysis. When I saw you put that in our outline here, and I was like, oh my God, I haven't seen that word in like forever, probably since I was at like med school clerkship of this. So
yeah, CV is going to be cytolytic vaginosis, as Meredith said, and it's a little bit more controversial. Like, there are some people who do not believe this exists. There are no good guidelines about it. There's not great guidelines on how to treat it and not great guidelines on how to diagnose it because it's like, pretty rare. And there's just not a really good consensus amongst specialists and infectious disease experts that this really exists. I do think I see this. I guess the biggest thing I notice, at least when I'm diagnosing this, is like these people have just the weirdest low pH. Like their pH will be 3.5, whereas usually the vagina is more like 4, 4.5. And so like I think, oh my gosh, that is really low. And there's not a lot of other conditions you're going to see with a really low pH. Usually high pH, DIV, bacterial vaginosis, low estrogen. Low pH, I mean, you can have a low pH and be asymptomatic, but if you have symptoms and have a low pH, this is on my radar.
In a low pH, that means it's acidic. So it can hurt.
It burns.
Yes.
Yeah, I've had patients, their main complaint is burning, or I've had patients say, it's just that my discharge, when it touches my skin, burns it. And so sometimes I've had patients say that like they feel better if they have a tampon in because then the discharge isn't touching their skin. Although there is some association with tampon use in this. So kind of a circular logic that gets me a little confused.
We're more beating around the bush of who knows what was what came
Yes.
first, the chicken or the
Yes.
egg. But also I feel like a lot of times when I see clinical pictures where I'm kind of suspicious of CV, they're using a lot of probiotics because there had something happen or whatever. And then so they're just throwing probiotics at it and throwing probiotics at it. And what you're doing is you're just pouring in this lactobacillus into the vagina, and that's lowering and lowering and lowering your pH, and you're just not really letting it recover. And so sometimes that's the easiest fix is to stop doing the probiotic.
Yeah, I mean, it really is an overgrowth of lactobacillus, and it's most associated with Lactobacillus crispatus, which is the one that's the best one, the good one, but it's like too much of a good thing. And so the pH gets too low. Actually, the pH is so low you can actually lyse the cells. That's how the cells kind of break open, and that's killing the cells, and that's what the cytolytic part is. The interesting thing, definitely I see burning, itching, but the discharge with CV is weird. So it can look like yeast. I mean, I've seen it where I'm like, oh my gosh, this looks exactly like yeast, like curdy, thick, like stuck to the vaginal walls, but like low pH, no yeast, yeast culture is negative. I've seen it look paste-like, sticky. I've seen it look kind of watery. And I've also seen patients feel like there's paper stuck in their vagina. Like it's just kind of this thick, dry discharge almost.
The period nerds that we are with hormones, think of scenarios where the pH of the vagina goes up and blood will make it go up. Blood is more basic and has a higher pH. So sometimes they'll also say, God, it kind of gets better with my period.
Yep.
And you're
Yep.
like, oh, there's a clue.
Yeah. So I've seen patients where it's better with their period and then it slowly gets worse each week. And then the worst week is right before their period and then it gets better. To me, that's a sign that like the pH is, especially too, if I look at the microscope or do a pH and it's low, basically the period's kind of resetting their pH to a more normal pH. And then they're slowly kind of reverting back to that low pH over the course of their cycle and it gets
It's really
worse.
cool.
Yeah, we're such
I think
nerds, but it's like fascinating, right?
I love the period. I wish people would just ask people about their periods. Like you can get so much out of it. Like you could symptom track it on these apps and be like, this is the time of the month that I feel better, I feel worse. And like for us, it's such a clue into what's going on. I mean, over your whole body with mood and all these things, but also your vulva and your vagina. It's the best. I just love it.
It's like a vital sign. I actually care more about that than your blood pressure most of the time.
For
It
sure.
tells me more. Although I do take blood pressure, so we talked about symptoms. So the things you may see, we already talked about the low pH, so pH 4 or less generally. And then under the microscope, you're going to see tons of lactobacilli. We're not going to be able to tell you which kind of bacteria, but lactobacilli look like little small bacteria that for this, like they're all over. And sometimes they're covering the cells. And usually you can see like cell debris because if there's been lysis of the cells, there's not a lot of white blood cells. So I always like to remember this is an osis, not an itis. So vaginosis, like bacterial vaginosis, not inflammatory. It's a dysbiosis. It means like an irregularity in the microbiome. So this, you're not going to see a lot of white blood cells.
That's a high pH thing.
Inflammation. Yeah.
This is a low pH.
Low pH. And then this would be negative for BV and yeast. So, you wouldn't see those things on here, obviously, because if you had those things, that would be what it is.
Yeah. Sometimes you see these ginormous lactobacilli too.
Oh, yeah.
They call them like the
Leptothrix.
Yeah. It's like they all like link up and they make this massive lactobus. It's really kind of cool when you see them.
Yeah. Sometimes I've seen people who have lots of them. And so that can be another subset of cytolytic vaginosis also. But so your diagnosis is going to be a constellation of the yeast-like symptoms with the itching, burning, weird discharge, low pH, too much lactobacillus, and negative swabs. And you really need someone who looks in the microscope and does pH to diagnose this. And treatment for this is really challenging. I mean, these conditions are probably some of the most challenging that we see. I will say that, the goal here is to raise your pH and reduce the number of lactobacilli that you have in there, but not get rid of all your lactobacilli and then have DIV. So we have to kind of I feel like there's a spectrum here. And like, sometimes I've gone from one to the other and I'm like, whoa, we overshot that. So like, we don't want to do that.
Flew too close to the sun.
Yeah.
These are kind of challenging, but if there's probiotics in the mix, like get them out of the picture because like sometimes that is the cause. So that's an easy fix because then your vagina will just kind of go back to its usual regular scheduled program.
The real thing that I usually recommend to patients that there's the most talk about or data about is using baking soda baths. So baking soda is going to be basic. It's going to raise the pH, which is what we're trying to do. So you could put a little bit of baking soda in the bathtub, and some of that will get in the vagina and hopefully help. You could even do an irrigation or a douche. I kind of hate to call it a douche because like we shouldn't douche, but it's a little different situation where you can put a little baking soda diluted in a bag and put it in there and irrigate. You also can make capsules. I highly recommend not doing that. I've heard they really, really burn. But the idea is that you're trying to get baking soda in there to increase the pH. And when I was looking through stuff, there is some data about using like a 4% sodium bicarbonate gel, which makes sense. It's just like basically you're making a vaginal gel that is a higher pH. But there's some studies on this, but there's really no commercial product for this. I have not actually tried using this. It's very interesting to me, but I guess we could compound it. We really want to use something that's going to raise that pH. I also read about using higher pH moisturizers, but I've not found those to exist either. So I usually try to do stop the probiotics and, as Meredith said, and some baking soda baths. I occasionally will use some clindamycin to see if I can get rid of some of the lactobacilli, and sometimes that will help, but I find it to be challenging.
That's why we're here today.
That's why we're here today.
The challenging stuff.
Challenging stuff. So I guess I will say there's no guidelines. It's not agreed upon amongst experts about this. So I'd say more to come, but I definitely feel like I sometimes see this in patients. So stay tuned for more information about this.
Hopefully.
All right. I think we talked about this last time, that so often patients, when they come to see us, have this like story of they had some like symptoms of things weren't quite right, like a yeast-like symptoms, and they called their clinician, they got some diflucan, or they took some over-the-counter monostat, they didn't get better, they went to the doctor, they did an affirm test, which if you listen to our last episode has a really high false positive BV rate. So they get diagnosed with Gardnerella BV, they take Metrogyl, Flagyl, they might get a little bit better, but it comes back, they go back again, they get more Metrogyl, and then now things are more irritated. Then they're starting probiotics because things aren't right, and then we're down this path, and now everything's negative, but you don't feel good. And I feel like that's when these two things come into play a lot. I don't find this to be all that often where it's just out of the blue these things start. There's some like process that's happened where things have been either misdiagnosed or not totally correct, and they've done some things to try to manage these symptoms, and it ended up here. Don't you think?
Yeah. When I was teaching residents, I would always say, if you're caught in this loop with your patients, get out.
Yes.
Get them to someone like us that's got a microscope and the pH paper, because it's hard, and it's hard on the clinician because it's frustrating for the clinician. It was frustrating for the patients. A lot of these patients just decide will have pelvic floor dysfunction because it is so stressful, and now they have tight muscles. So it's a very big picture. And of course, mentally, it can affect them. There's stress. It's stress on relationships. And they can have pain with sex, or they don't want to have sex because it's discharge, and they're worried about that. And is this going to make it worse? So there's a lot of things to consider in these scenarios.
Yes, absolutely. And I'm glad you brought up the pelvic floor, because once you're in pain, you clench, and then you have pain somewhere else now because you're clenching. So that could definitely be part of it. So because we're talking about zebras or rare things, I want to just quickly highlight a couple other things, not in a lot of detail, that you should be thinking about. If all these swabs are negative and patients are having discharge and pain, I want you to think about these other things. One is atrophic vaginitis or genitourinary syndrome menopause. So this is just estrogen deficiency in perimenopause or postmenopause, or you can have it for other things too. You can have it during breastfeeding, if you're on birth control pills sometimes, or if you're on a aromatase inhibitor or a SERM for breast cancer risk reduction, things like that. But basically low estrogen, and they actually get this inflammation from not having enough estrogen. But their exam's going to look pretty different than it would for DIV, but under the microscope, it can actually look somewhat similar, where you have lots of white blood cells and a lot of lactobacilli and lots of those parabasal cells. So you always have to take the whole history into account, because I definitely think patients can come in with symptoms of vaginitis, have negative swabs, and this is really what it is. They just need some vaginal estrogen.
Yeah. Everyone needs it.
Everyone needs it. It should be in the water.
Other zebras.
There can be allergic reactions. So if patients are using a new soap or detergent or even probiotics, condoms, there are certain things you can have a reaction to, and you can get like an allergic reaction. If you can identify what that is, they can stop using it, but they could get burning and some discharge from that. It would look different than DIV, most likely. Do you want to talk about lichen planus briefly?
These are autoimmune skin disorders. Lichen planus is one that we see in the vulva, but we also can see it in the vagina. Lichen sclerosus, like we talked about, does not go past the hymen into the vagina. So it's really just lichen planus. These are just really inflammatory autoimmune skin disorders, and that can cause erosions or kind of look, they almost look like, they're not ulcers, but they're kind of just like really superficial, kind of abrasions almost they look like in the vagina. And those can cause a lot of inflammation and kind of this clinical picture. Then, of course, there's the pemphigus and mucous membrane pemphigoid, which my dermatologist always like to put on the differential. And then I have a panic attack and I'm like, okay, that's where you guys come in.
Right.
Because we do not treat that. That's definitely more dermatologic and needs a dermatologist.
So lastly, I want to talk about foreign body vaginitis. And we've talked about this in other episodes, I think our odor episode. But sometimes there's something that's left in there, not on purpose, usually. But sometimes people forget about a tampon in there or a condom can come off and you don't know it's there. And the vagina does not like that. That makes the vagina mad. And so it will have an inflammatory reaction, try to get rid of it. And it can cause some really icky, foul odor discharge. Every gynecologist has taken a retained tampon out, and it is one of the most foul smells. And we just try to let people know that this can happen to anybody. None of us are like, oh my gosh, I can't believe that lady did that. This could happen to any of us.
Any other day for us.
Any other day. If you're a patient, you have a lot of foul discharge and odor, and if you think through it and you're like, oh, I wonder, I mean, definitely go see your someone to make sure there's not a tampon in there too. And, a lot of this episode, we've been talking about like what this may look like. I do, a lot of our content is really for patients who are struggling with these things, but I do hope that there are some clinicians out there that are listening to this too. We always say we didn't learn a lot of this in residency. And I do think it's worth knowing about these things. Even if you don't have a microscope or pH paper in your office to be able to do these things, at least knowing about them so you can get patients to the right place or even presumptively treat some of these things. I'd rather you have the data to say that this is what this is, but I think knowing about it is half the battle. So sorry if we got a little bit into our microbiology under microscope kind of stuff. Some of my patients are like, can I come look in the microscope with you? And I'm like, sure. I mean, it's so cool.
Yeah.
And then even though I don't think that this should exist, I've seen it with my own eyes. You can have like a mixed vaginitis. You can have like yeast and BV. Yeast and BV shouldn't live in the same world because they have different pHs generally, but I've seen it with my own eyes. And it can be confusing and kind of tough to treat. You could also, as the last part of like weird zebra thing you could have is that you could have more than one thing going on. So I think in summary that negative swabs don't mean that you don't have something wrong. If you feel like something's wrong, something's probably wrong. And you should keep trying to figure out what's going on. You should try to find a clinician. If you've had a lot of negative swabs and things aren't right, try to find a clinician that has the capability of doing a pH and looking under the microscope. A lot of clinicians don't anymore, and it's not their fault. Some of these central labs have taken the microscope away from them, and these clinicians may really want to be able to do this for you, and they just can't. So it's not their fault. And then, don't just keep throwing antibiotics at it because that just screws up their microbiome. And then we got to piece back together the whole thing and it's hard. So don't just keep throwing antibiotics or antifungals. Do an exam, figure out what's going on. And for patients, if you're in that loop, like Meredith was talking about, like it's time to get out of that loop and find someone that can help you. And, all these things are a little bit controversial. There's a lot more data needed about them. So I'm hopeful there's going to be more treatments and more information about why these conditions happen so we can better treat patients. So stay tuned for that.
Yeah.
And if you're in this situation as a patient, I just want to say I'm sorry. I know this is a really hard place to be, and it's really hard to not know what's going on. And it's really hard to have a pissed off vagina and vulva. So I hope you can find your way to someone that can help you because these things are really hard.
Thanks for joining us. This has been fun. We tackled some zebras that are really challenging. And I think we did pretty well with it, Ashley.
I think so. We were a little worried about it.
We were totally worried about doing this episode. It can be a little
challenging talking about these things. But I hope that you, as a listener, got something out of this. If you like our content, please like us on Apple Podcasts or wherever you get your podcast. Leave us a comment, especially if it's a good one. We're trying really hard. We love what we do. We're big geeks about it, obviously, but we just really want to share the education because we didn't learn this stuff in residency. And a lot of patients are looking for answers, and we're trying to help both patients and clinicians get to those answers.
So Dr. Fuller, maybe someone's listening to this episode and doesn't know where to go or who to look to. How do people find people that can provide these kind of services?
Right. That's a great question. I actually get emails sometimes from patients saying, I don't live in Washington State. I can't come see you, but I need someone for this. If you go to ISWISH, International Society for the Study of Women's Sexual Health, Their website, they have a clinician finder page, and I think ISSVD also does. So International Society for the Study of Vulva Vaginal Disease. So these are people who are going to be vulvar experts, vulvar specialists, and should be able to help you. ISSWSH is a little bit more multi-specialty, and so you're going to find on their list sometimes some pelvic floor PTs and sex therapists and things like that. But if you look for the clinicians, you should be able to find on their page how much of the stuff they do, and most of them will be very educated in this.
Thanks for joining us for this episode of Labia Logic.
We get it. Sharing a podcast like this might feel a little taboo, but we're here to break down those barriers. Labia Logic's all about empowerment, not embarrassment.
If you found this episode helpful, we hope you share it with others who could use a little labia logic in their lives. Can't we all? You can find us on all major podcast platforms and connect with us on Instagram at labia_logic.
From our lips to yours,
Viva la vulva!